Hello, my name's Tim Tanzer. I'm a clinical pharmacist and a researcher in the safe use of medicines for mental health conditions. Today we're going to focus on sodium valproate, which is an anticonvulsant commonly used in the treatment of both epilepsy and bipolar disorder. And we're going to talk about how albumin levels, which is a protein commonly found in the blood, can affect the amount of valproate that enters the brain, and thus affects the dosing and the safety of valproate. In this video, I hope to give you some insight which will help you collaborate with other healthcare professionals and ensure that our treatments are not only safe and effective, but are evidence-based. Valproate is a versatile drug that stabilizes neuronal firing rates and prevents abnormal electrical activity in the brain, making it useful for various types of epilepsy, managing mood swings in bipolar disorder, and even treating migraines. The exact mechanisms by which valproate works are complex and not entirely understood. The metabolism of valproate is also very complex, and although we know some of its metabolic pathways, there are many aspects of its metabolism which remain unknown. We do know that valproate interacts with a wide range of enzymes and biological systems that can vary significantly among individuals due to genetic and environmental factors. This brings us to the importance of therapeutic drug monitoring in valproate therapy. Therapeutic drug monitoring is vital for drugs like valproate, where there is such a large difference from person to person, and so we need to measure the amount of drug in the blood to make sure that the level is within a safe range. Therapeutic drug monitoring is useful in both epilepsy and bipolar disorder to check for patient adherence, to manage side effects, and to make dose adjustments in response to changes, such as the addition of a medication that may interact with valproate, or physiological changes such as change in albumin levels. It's all about making informed decisions around dosage. A significant known aspect about valproate's pharmacokinetics is its interaction with plasma proteins, mainly albumin. Under normal conditions, around 90% of valproate is bound to albumin. And this is really important because it's only the unbound or free valproate that is not bound to albumin that can cross the blood-brain barrier, enter the brain, and have therapeutic effects. Changes in albumin levels, which can occur due to various medical conditions such as chronic disease, acute illness, malnutrition, and aging, can therefore impact the amount of free valproate. So if the albumin level is low, the amount of free valproate will be higher. And that means there's a greater amount of that total valproate, which is crossing the blood-brain barrier, entering the brain, and having an effect, and also maybe causing side effects or toxicity. Let's now observe this effect with a case study. In our case, we have John. He's 42 years old. He was diagnosed with bipolar disorder 10 years ago and has been stable since. Currently, he's on Valproate 1,500 milligrams per day for mood stabilization. John presented to an outpatient clinic for a routine follow-up. He reports feeling generally unwell and mentions recent unexplained fatigue and occasional confusion, which he has not experienced before. If we look at the lab results for John, our albumin levels are significantly lower than normal at 30 grams per litre. The normal range would be 35 to 50 grams per litre. The liver function tests are slightly elevated, and we've done a total valproate plasma level, which has come back as 75 milligrams per litre. So the usual therapeutic range for valproate is considered to be 50 to 100 milligrams per litre. Sometimes you might see that range set higher, particularly in refractory epilepsy. You may see it as high as 125. So our clinical question is as follows. Given John's current condition and lab results, what would be the most appropriate action regarding his valproate dosage? A. Maintain the current dose. B. Increase the dose to counteract the low albumin level. Or C. Reduce the dose to decrease the risk of toxicity. So the correct answer here is very likely C. Given John's low albumin level, it is likely that there is a higher proportion of free valproate that is crossing the blood-brain barrier despite a level that is therapeutically in range. Symptoms of fatigue and confusion are concerning and could be early signs of valproate toxicity. So lowering the dose might be the most appropriate option because it will allow us to maintain therapeutic efficacy in light of the low albumin, while also minimizing side effects and toxicity. However, while reducing the dose may lower the potential for toxicity, doing so might pose a risk of undertreatment of John's bipolar symptoms. For someone who has been on stable treatment for 10 years, undertreatment may have significant consequences. So the question is, by how much should we reduce the dose? This is where I'd like to introduce you to the Valproate calculator, which adjusts valproate levels based on albumin levels. At first glance, this calculator serves a useful purpose. It offers a neat solution to our problem. If we were to input the values from our case study, we would find that the adjusted valproate level is quite high at 173. And this would suggest that we should be reducing the dose by around 30 to 50%. However, we already know just how complex the metabolism and action of valproate is, and just how much variability there is from patient to patient. And so we ought to have a healthy dose of skepticism anytime there's a very simple and elegant solution to a very complex problem. So in the interest of keeping our practice evidence-based, let's dive into the literature that informs the calculator and see if it's too good to be true. So when we click the link to show us which paper informs the Valproate calculator, it shows us this paper by Ermida and Tutor. But before we look at this paper, let's go back to the first paper that was published on this topic in 1993. In this paper by Parent et al., the authors collected 29 samples from 22 patients, and there were 16 men and 6 women in this dataset. The authors then assessed the serum concentration of valproate with the albumin levels. So, as you can see in this table, what they found was as the albumin levels go down, the estimated free fraction of valproate goes up. And this is consistent with what we know in our understanding of the interaction between valproate and albumin so far. So the authors did take this data and they put it into what's called a decay function. And we'll come back to this later. But this decay function basically describes the relationship between albumin and free valproate fraction. This is an attempt to describe the relationship that they observed. This paper is essentially a case series. It's designed to describe the presentation and course of cases that are reported in the study. It is not designed to draw any statistical conclusions, nor did the authors actually conduct any statistical analysis. So although the authors did describe the relationship in a function, in no way do they suggest that this function has predictive power or should be used in clinical practice. That would require a different study design, like a randomized controlled trial, or a high-quality cohort study. So let's go back to this second paper by Ermida and Tutor, the one that informs our calculator. So this second paper by Ermida and Tutor aims to build upon the research that was conducted by Parent et al. By suggesting an equation for normalizing total valproate concentration in patients who have low albumin. And in the introduction, they suggest that the previous equation, the exponential decay function from Parent et al., would make this possible. Let's quickly recall that in that previous paper, the authors did not do statistical analysis, nor did they validate this equation. So Ermida and Tutor in this paper are setting out to do that by validating this equation against their own dataset. So in this paper, the authors collected samples from 121 patients who were receiving valproate and had a low albumin level. And what they found was this. In this first graph here, the authors are plotting their new samples that they've collected on a graph. And this graph is a scatter diagram that is telling us how accurate the original predicted equation was to the real observed values that the authors found. So ideally, if the equation was perfect and it predicted all of the values, we would see these samples sit perfectly along this dotted line. However, what the authors found was that there was this cluster of patients with low valproate levels where it sat kind of close to the prediction made by the calculator. But for patients who had high valproate concentrations, the distance away from the values predicted by the calculator is very high. This suggests that the model or formula becomes less accurate the higher the valproate level is. And I think that we can safely argue that these patients with high valproate levels are the ones that we really care about when it comes to toxicity. So the authors noticed this, and so they decided to actually split the data between those with low concentration and those with high concentration. So in our second graph, they split the data into two new models. So those with the white circles are the low concentration of valproate patients, and those with the black circles are the high valproate concentration patients. And we can see that when they did split the data into these two different models, the observed values are much closer to the predicted values. However, there are several issues with this. Not only have they arbitrarily split the data and therefore lowered the power of each model from a study that didn't have a lot of samples to begin with, they've also lowered the generalizability of their findings. Secondly, they've taken a biological mechanism that we know for sure is not linear, and they've attempted to put straight lines through that data, which is a bit of a faux pas when it comes to statistical analysis. That doesn't mean you can never put a straight line through a function that you know is not linear, but the question then becomes, is that straight line useful? If you recall, the original equation that observed the relationship by Parent et al. In the previous paper, it wasn't a linear equation, it was an exponential decay function. And so the data more likely looks like this. And biologically, this makes sense. The number of binding sites on albumin will be limited, and therefore it's not possible for the amount of valproate binding to stay linear. Furthermore, although the authors did attempt to find new equations that loosely fit the data presented, they still did not conduct any statistical analysis. So without p-values or confidence intervals, we don't know for sure whether or not this is valid and holds true for different patient samples or the wider population. I could plot a linear relationship between the number of clouds I see on my way to work and the number of purple cars I see on my way home. And I could put a straight line through that data and come up with a formula. But without statistical testing, there is no way for me to say whether or not that relationship actually exists. So if we come back to the question of no model is perfect, but is this model useful? The answer is no. In fact, using a calculator such as this may lead to inappropriate dose adjustments and undertreatment of patients with bipolar disorder and epilepsy who may be medically unwell. In fact, I would safely argue that this paper actually provides evidence that not only is the calculator not reliable, it is also not clinically useful for the patient group for which we are most concerned. And so at this point in time, there is no evidence to support the use of a valproate calculator in clinical practice. So let's finish off with one more case study. In this case, we have Graham. He's 37 years old. He was diagnosed with bipolar disorder 3 years ago and has been on sodium valproate since. Currently, he's on 1200 milligrams daily of sodium valproate. During a routine checkup, blood tests reveal that Graham's albumin level is low at 32 grams per litre. He reports no new symptoms and generally feels well. Alan, the pharmacist, noticed that the albumin level is low and questions whether or not we should adjust Graham's Valproate dosage, thinking that the low albumin might impact the efficacy of Valproate. He suggests we use the adjustment calculator in order to calculate a new dose. So the clinical question is this: given Graham's stable condition and the recent lab results showing low albumin levels, what should we do next regarding the sodium valproate dose? A is increase the dose by 10% to ensure therapeutic efficacy. B is to reduce the dose by 10% to mitigate potential toxicity. C is to maintain the current dose and monitor Graham. And D is to order a free valproate level and assess other clinical parameters before making any adjustments. So the correct answer, if you said C or D, you are likely both correct. Given Graham is symptomatically stable and reports feeling well, the best course of action is to maintain the current dose and monitor for any signs of toxicity or loss of efficacy, even though the albumin level is low. Now, if you said D and wanted to order free valproate levels, that would also be correct. Free valproate levels measure the amount of unbound valproate in the bloodstream, and so they may be clinically useful for patients who have low albumin levels and have suspected toxicity. However, free valproate levels require specialized equipment and expertise, and so they are costly and time-consuming, and they may not be readily available in the clinical setting in which you work. Also, free valproate levels are generally considered no more useful than total valproate levels because the reference ranges for both are not very well defined. And because there is so much variability from patient to patient, the best course of action is to always adjust the dose based on the clinical response and the presence of side effects. We should always treat the patient and not the numbers. Okay, let's finish off by discussing some practical guidelines for optimizing valproate use. 1. Every patient is different. Always perform a thorough clinical assessment and adjust the dose based on clinical response and the presence of side effects. Just because someone has a valproate level within therapeutic range does not mean that they cannot experience toxicity. 2. Watch for interactions. Be aware that medications can affect valproate levels, and physiological factors such as albumin level can also affect the free fraction of valproate. 3. Always perform therapeutic drug monitoring when using valproate. Monitor total and, if available to you, free valproate levels, especially when patients have low albumin. 4. When making dose adjustments, go slow and steady. Gradual dose adjustments are the way to go. If a patient experiences mild to moderate symptoms of valproate toxicity, generally a 25% reduction in dose is reasonable, and monitor the patient closely for changes in response. If the patient experiences severe signs of valproate toxicity, they may need urgent supportive care, and a toxicologist or neurologist should be consulted. As a final note, remember that clinical tools such as dosage calculators should be supplementary to your decision-making. They can help to inform your decisions, but they should never replace good clinical judgment. Before you use any tool like a dosage calculator, always ensure that it is supported by good science. At this point in time, there is no evidence to support the use of a calculator for adjusting valproate levels in patients with low albumin. However, in the future, somebody may better define the relationship between albumin and free fraction of valproate, and we may have a clinically useful calculator available.